The broadcast is now starting. All attendees are in listen-only mode.
Dr. Laban, all yours.
Good evening, everybody. Thank you for joining us tonight for our webinar on life-threatening conditions in epilepsy. My name is Olgica Laban-Grant. I'm one of the epileptologists with Northeast Regional Epilepsy Group. Death is never an easy topic to raise or to discuss. Most of people feel uncomfortable with it. Some doctors choose to avoid this subject so not to raise any alarm. However, it is a very important topic, as awareness is the best way to prevent unexpected death. It is estimated that up to 50,000 deaths occur annually in the United States from status epilepticus, sudden unexpected death in epilepsy, and other seizure-related causes such as drowning and other accidents. I will first define some of the terminology that I will use tonight. Standardized mortality ratio, or SMR, is the ratio of observed deaths compared to expected for the same age and gender. So for the general population, SMR will be 1. Everything above 1 means that there is a higher than expected risk of death for that age and gender. The other way to look at it is as deaths in person year, and that includes the duration of the underlying condition, in this case epilepsy. 1 equals that 1,000, for example, that we have to follow up 1,000 people with epilepsy for 1 year to detect 1 death. People with epilepsy have 2 to 3 higher risk of premature death than general population. And this is number for North America and Europe. SMR is 2.2. However, in some countries, risks are sometimes reported as 4 to 5 times higher than general population. However, this depends also on circumstances. In epilepsy lasting at least 4 years, SMR is higher at 3. It's also higher in first 5 to 10 years after diagnosis. New onset epilepsy, for example, has SMR of 2.6. SMR for people with idiopathic epilepsy, or epilepsy in which we do not know underlying cause, does not seem to be increased. However, SMR for children with epilepsy seems higher because mortality rate among children is very low. So if you look at this slide of mortality by age in epilepsy patients, it seems very high in first 2 years of life. But that is because the death rate in general population at this age is very low. The other way to look at it is life expectancy. It appears that there is a 10 years of life lost for epilepsy with known cause, so-called symptomatic epilepsy, while 2 years of life lost for epilepsy of unknown cause, or idiopathic epilepsy. What are the risks for premature death? Strongest risk for increased mortality are having symptomatic epilepsy. The cause has been identified, and usually this is because of the underlying condition or underlying abnormality that is cause of death, not necessarily due to seizures. Then failure to obtain 5-year seizure remission, and this is because we're talking about the epilepsy that is difficult to treat. Younger age and onset of epilepsy, and non-compliance to anti-seizure medications. I want to stress non-compliance because this is one of the risks that is modifiable. And there are reports that this may increase risk over 3 times of a premature death. This slide shows the cumulative rate of death in patients with idiopathic epilepsy or epilepsy of unknown cause. This is the lower line, which shows the lower cumulative death rate, compared to the symptomatic epilepsy, that is the full line on the top, which are the types of epilepsy in which we know the cause. Other possible risks that were reported but not confirmed are male gender, generalized tonic-clonic seizures, and cognitive impairment. Causes of death in epilepsy are usually related to the underlying cause of epilepsy. And their minority are deaths directly related to epilepsy, such as accidents, status epilepticus, and sudden unexplained death in epilepsy. We will briefly talk about these deaths that are directly related to epilepsy. And I will very briefly talk about accidental death in epilepsy, because this is something that is obvious and most of the people are aware of. So accidental death may occur most commonly due to drowning, but also due to choke, suffocation, or head trauma. The estimates of how frequent this happens are very variable, anywhere between 1 and 27% of deaths in epilepsy patients. Risk factors are also obvious. Longer duration of epilepsy, increase in seizure frequency, and side effects of anti-seizure medications are all to be responsible for this accidental death. We'll talk more about the other two causes of death that are related to epilepsy. And first, we will focus on status epilepticus. Current definition of status epilepticus is continuous seizure lasting more than 30 minutes or 2 or more seizures without full recovery of consciousness between any of them. However, most of the physicians take this practical approach and treat any seizure that lasts more than 5 minutes as possible status epilepticus. Reason for that is that spontaneous termination becomes less likely in seizures lasting over 5 minutes, and the longer the seizure continues, the more difficult it is to control the seizure with anti-epileptic drugs. So it's very important to try the treatment as soon as possible instead of waiting for the 30-minute mark. How frequently it happens? In the United States, it's estimated that it happens between 6 and 18 per 100,000 people. About a quarter of these patients are patients with epilepsy. Age follows so-called J-shaped curve, so that means that there is a peak in early age and less than 12 months old, usually because of the underlying neurological condition that causes seizures. And then in elderly, over 6 years old, it is 86 per 100,000 per year. Causes of status epilepticus include medication withdrawal, and again, I wanted to stress that because this is easily modifiable. Then strokes, alcohol withdrawal, low oxygen supply of the brain causing anoxic or hypoxic brain injury, metabolic disorders, and then different infections, tumors, traumas, and drugs. It depends also on the age. In children, it's usually infection. In elderly people, it's usually stroke. Status epilepticus has 2 stages. Stage 1 is stage of compensation in first 30 minutes of seizure. After that, we enter stage of decompensation for more, when the seizure lasts over 30 minutes. That is because in the first 30 minutes, body is able to compensate for all the demands that this ongoing seizure presents. So the heart rate increases, blood pressure increases, the respiration increases, but everything is compensated, everything is working fine, and body is able to keep up with the increased demand. But after 30 minutes of ongoing seizures, the systems start to fail. And at that time also, electromechanical dissociation may occur. What that means is that the brain electrical seizure activity continues, but visible manifestations may be restricted to just minor twitching or none at all. And this is very important because everybody needs to have very high level of clinical suspicion for this stage of status epilepticus because it may not be obvious that the patient is still having seizures. And therefore, it is very important to look for these minimal signs of possible seizure. Consequences of status epilepticus is dysfunction of the heart and lungs, metabolic changes, increase in body temperature, permanent brain damage, which usually causes cognitive impairment and death. Neuronal loss or loss of brain cells is linked to the abnormal neuronal discharges and not simply to the effects of the seizures. Prolonged seizure activity results in pathologic changes after 30 minutes, and neurons begin to die after 60 minutes. The hippocampus is part of the brain that is especially vulnerable to damage by this mechanism, and because of that, people who did not have epilepsy may develop epilepsy after status epilepticus, and also may develop cognitive problems that are common long-term consequences. When we look at the risk of death in status epilepticus, we're not looking at risk only during the seizures, but within the 30 days after the status epilepticus, because of all the changes in the body which can result in increased risk for death. It is uncommon in children, only 30%, while in adults it goes up to 26%. If you look at the elderly population, risk of death from status epilepticus within 30 days is 38%. So geriatric population is very vulnerable to the status epilepticus. Cause also determines the prognosis. Death is most often related to the underlying cause of brain injury. So the worst outcome is in the patients who had stroke or hypoxia, lack of oxygen supply to brain. The better outcome if seizures occur due to the alcohol withdrawal or low levels of anti-epileptic drugs. So the patients with epilepsy usually have a little bit better prognosis or lower risk of death in status epilepticus than people who never had epilepsy before. There are as many types of status epilepticus as there are seizure types. So any type of seizure may progress into status epilepticus. But for practical purposes, we usually look at the status epilepticus as convulsive and non-convulsive. Convulsive means ongoing tonic, clonic, or myoclonic seizures. Non-convulsive usually presents as a confusion, twilight state, or unresponsiveness. And again, it's very important to think about status epilepticus in order to diagnose it, because non-convulsive status epilepticus is diagnosed with EEG. There are different types of non-convulsive status epilepticus. Absent status epilepticus of mild seizures usually have good prognosis. However, subclinical status epilepticus usually have worse prognosis, and that is because it's usually a consequence of untreated convulsive status epilepticus. As I said earlier, if convulsive status epilepticus continues, there is this electroclinical dissociation in which the seizure in the brain continues while there are no clinical manifestations. So usually the non-convulsive status epilepticus means that the seizure has lasted for a long time. So that's why we think that for the subtle generalized convulsive status epilepticus or non-convulsive status epilepticus, the risk of death within 30 days is 65% compared to 27% in generalized convulsive status epilepticus. And again, duration is very important. So if the seizures stop within an hour, the risk of death is about 3.7%, but if they last over 1 hour, there is a steep increase in the risk to 35%. The longer an episode of status epilepticus continues, the more refractory to treatment it becomes. So if the medications are given within 30 minutes, 80 people stop seizing. But if they were given after 2 hours, only 40%, so only half of that responded to medication. It is very important to start treatment before even arrival to hospital. And the reason for that is because the brain cells change in a way that they do not respond to medications anymore. So the patient will require much higher doses of medication or sometimes will not respond to medications if the medications are delayed. So the treatment of status epilepticus starts with stabilization of vital function. That's why it's very important for family and friends to know CPR and resuscitation techniques so that they can maintain airway, breathing, and circulation at the beginning of the status epilepticus. It is also extremely important to stop the seizure and then search for cause and try to treat the underlying cause and improve treatment of seizures. But because of this effect of the electric activity of brain on the survival of the brain cells, it is most important to stop seizure. And that is done with medications. Benzodiazepines is a group of medications that act very quickly, and they can be given either intravenously, intramuscular, or rectally. So they can be given at home, they can be given in the ambulance, and of course they can be given in the hospital. Anti-seizure medications are given intravenously or intramuscularly. Currently they are given in hospital only, but they are now doing studies to allow emergency medical personnel to give the first dose of anti-seizure medications in the ambulance. If the seizures do not respond to anti-seizure medications, sometimes these patients are placed under general anesthesia, sometimes for days, in order to try to control the seizures. And I mentioned surgery as one of the treatments for epilepsy, which is status epilepticus, which is very uncommon. But if the status epilepticus is focal from a clear ictal focus, and sometimes surgery is also used for the refractory status epilepticus. So what can patients and families do to prevent this? It is very important to stay compliant to anti-seizure medications and not to stop them abruptly, because that is one of the highest risk factors for status epilepticus. It is good to have a seizure emergency plan and use medication to stop the seizures that last over 5 minutes or clusters of seizures. It is important to learn to recognize subtle signs of ongoing seizure, and it's very important to act quickly. In the United States, only Vectal diazepam gel or Diazepam has been approved by the FDA for out-of-hospital use for the treatment of acute repetitive seizures or clusters. In some other countries, they use also Versed or midazolam, and currently this is also evaluated in the United States for intranatal treatment. We will now talk about sudden unexplained death in epilepsy, or SUDEP. This is the definition of SUDEP. Disease has to have epilepsy. The death occurred unexpectedly. The death occurred suddenly. Death may have been witnessed or unwitnessed. And this is very important. Evidence of preceding seizure is not required. Death occurred during normal activity in benign circumstances. It was not consequence of status epilepticus, drowning, or trauma. And post-mortem, after death, examination did not demonstrate a cause of death. We assume that SUDEP, or sudden unexpected death in epilepsy, occurs because of seizures, but really we don't have proof for that. So that is not required for the diagnosis of SUDEP. How common is SUDEP? It's not very common. It occurs in 0.1 to 2.3 per 1,000 patient years in population-based studies. But it's up to 9 per 1,000 in refractory epilepsy and the patients who are evaluated for epilepsy surgery. Sudden death is 24 times more likely in people with epilepsy. It's uncommon in children, and as I mentioned previously, it's more common in refractory epilepsy. It seems that absence or myoclonic seizures are not increasing risk of SUDEP. What causes SUDEP? We don't know. Probably there is more than one cause, and the causes of SUDEP may be different in different individuals. These are the theories: electrical shutdown of the brain, problems with the heart, or problems with breathing. Problems with the heart. So there is abnormal heart rhythm sometimes associated with seizures. There are conditions that may cause both seizures and abnormal heart rhythm. Problems with breathing. More than expected number of patients is found in bed prone, so suffocation is one of the possible mechanisms. However, sometimes the seizure may cause breathing to stop, or can cause the accumulation of fluid in lungs. And finally, so-called electrical shutdown of the brain. Brain decreases the activity after the seizure to stop the seizure. Sometimes this is so pronounced that it results in cessation of breathing and then heart rhythm, and then results in death. And this was recorded in some of these SUDEP cases that occurred in the epilepsy monitoring unit. These are the risk factors. Adults, as I mentioned previously, are more commonly dying of SUDEP. Frequent convulsive seizures, nocturnal seizures, early age of onset of epilepsy, long duration of epilepsy, higher number of anti-epileptic medication and in high doses, frequent medication changes, and learning disability. Protective is supervision. If you look at this risk factors, many of them just mean that the epilepsy is difficult to treat. So frequent convulsive seizures, early age, long duration, high number of anti-epileptic medications, frequent medication changes, they all suggest that this is difficult to treat epilepsy. Learning disability suggests that this is symptomatic epilepsy. But how about supervision? One study showed that there is a significant reduction in SUDEP in a population that was supervised. And by supervision, they meant that somebody 10 years or older of normal intellect is in the same bedroom, or that there are regular checks throughout the night, or that there is a use of listening device. And why do we think that this prevents SUDEP? Probably by detecting seizures early, repositioning, and stimulating the patient to avoid its electrical shutdown or maybe suffocation due to seizure. But we really don't know why the risk of SUDEP was decreased in supervised patients. So what can be done? There are anti-suffocation pills. It is unclear if they're helpful because suffocation is just one of the possible causes of SUDEP, and we really do not know whether the anti-suffocation pills will prevent suffocation at all. Then there are many detection devices. None of them are FDA approved for seizure detection, so we don't know how well they detect seizures. And if they do detect seizures, they will detect mostly convulsive seizures, not non-convulsive seizures. Whether these devices can prevent SUDEP remains unknown, because even when the seizures are detected in epilepsy monitoring units, some of the patients still died of SUDEP despite the medical personnel being there and doing the resuscitation. So we don't know whether the terminal event is reversible or not. The devices that are available are most commonly detecting motion. Those are the mattress devices, watches, video devices. They do not detect breathing or heart rhythm abnormalities that may be cause of SUDEP, and seizures may not precede SUDEP, as I mentioned before, and they will not detect non-convulsive seizures. Multimodal devices that are monitoring motion, oxygenation, electrodermal skin response, heart rate, respiratory rate, and rhythm are being developed. It is uncertain whether they can prevent SUDEP. So what can be done? The most important thing is to maximize seizure control, so to stay compliant to medications, to avoid triggers, to have seizure emergency plans, and to consider epilepsy surgery or diet if the medications are not working. Nighttime supervision seems to be helpful, and families should know resuscitation measures, although we are not certain whether the terminal event is reversible or not. As a conclusion, seizures themselves are rarely fatal. Awareness is the first step in finding the cause and improved prevention of death in epilepsy. Seizure control, prevention, prediction, detection, and the response to seizures are all important in minimizing the likelihood of a death. So be seizure smart and know your risk. Thank you very much for joining our webinar.